Let me welcome Dr. Rob Morgan. Dr. Morgan is an assistant professor of psychiatric hospital practice up in Rochester, and he's going to talk about a waxing and waning diagnostic dilemma.
That will be one of the cases that we talk about later. For right now, I'm going to try to talk a little bit about agitation management in the ICU from a psychiatrist's perspective, but also try to incorporate some of the ICU perspective as well. And it's really going to try to be focused on the ICU, although there's so much overlap between agitation management in the ICU and on the general medical floors that it's virtually impossible to isolate this talk to the ICU setting. And that's consistent across all of the talks that we're giving this morning on the ICU management and diagnostic situations. There we go. All right, so the objectives of this talk are to identify risk factors for agitation in the ICU, describe approaches to prevent development of delirium in ICU patients, describe some non-pharmacologic approaches to management of agitation, particularly in the ICU, but these will be generic as well, and identify pharmacologic approaches to managing agitation due to delirium. Notice that I do not say managing delirium pharmacologically. Agitation in the ICU is quite common, and again, the definitions here are challenging, and so thinking about that idea of psychomotor disturbance, an increase in psychomotor disturbance, whether that's verbal, whether that's physical, whether that's any kind of psychomotor disturbance that a patient might have, may qualify for increased agitation. And the reason that we really care is because that interferes with patient care, and it causes a risk for aggression and dangers to that patient as well as the staff who are caring for that patient. So it's about a fifth to a half, depending on the studies that you look at, of patients in the first 7 days in the ICU will develop agitation, and this typically is 2 to 3 days after admission. It's much more common in the ICU than on floors, so in the ICU you will almost certainly encounter patients with agitation. There are some ICU-specific risk factors as well, and also the type of ICU matters. So not all ICUs are created equal, and in trauma ICUs, there's probably a greater degree of agitation than there is on medical ICUs. Burn units also fall in there with a great deal of agitation, so it depends on where you're working as far as how likely you are to encounter agitation and the types of agitation that you might encounter. So some physical risk factors for agitation and things that are really pertinent to the ICU, essentially all of these. So pain, withdrawal symptoms, sleep deprivation, mechanical ventilation itself is a risk factor. Visual and hearing impairments, speech impairments, something we don't think about too much, but lack of ability to utilize toilet facilities is a risk factor for agitation. Hunger, thirst, lack of ability to eat, having tubes in, these are all risk factors, and mobility.